Williams lecture for today. Our lecturer for today is Dr. Ricardo Nuila, and I will introduce him in a moment. But first, I would like to talk a little bit about our the supporters for this lecture series. The first is the J. Richard Williams Senior Endowment. This was initiated in the fall of 2013, and it supports these lectures on spirituality and health at the Tulane University School of Medicine. The goal of the lecture series is to focus on the art of creating a compassionate and trusting relationship between patients and doctors. The series honors the legacy of J. Richard Williams Sr., a Tulane University graduate who was a well-known, well-loved internist and oncologist in Selma, Alabama. Dr. Williams loved medicine and was the kind of doctor who would do anything for his patient, and had an interest in the impact of spirituality on health, particularly on the positive impact of spirituality on the well-being and continued health of those who have suffered the loss of a loved one. And we are very, very thankful to the J. Richard Williams Sr. Lecture series for continuing to support these lectures in medical humanities and bioethics. Our second source of support is the Bioethics and Medical Humanities program at Tulane University. The Bioethics and Medical Humanities program is a soon-to-be 30-hour program that can be completed in 1 or 2 years, and involves a focus on either bioethics or medical humanities, although all graduates get both bioethics and medical humanities. The bioethics track focuses on teaching, research, and service through Hospital Ethics Committee and Institutional Review Board service, teaching, of course, in all healthcare settings, and conducting normative or empirical research in healthcare ethics issues. Our medical humanities track focuses on teaching or research on those aspects of narrative, reflective writing, fine arts, and history as applied to healthcare. If you have any interest in seeing more about our program, it's very easy to find us. It is tulane.edu/bioethics. And you can find more about our program in the Masters of Science program, or our graduate certificates in clinical ethics, research ethics, or medical humanities. If you have further questions, you can contact me, that's Stephen Hanson, SHANSON 4 @tulane.edu, or medicalethics@tulane.edu. And we would be glad to follow up with you. Now, without further ado, I would like to introduce our speaker for today. Dr. Ricardo Nuila works as an internal medicine doctor and a hospitalist in what was my hometown and is his hometown of Houston, and works at Ben Taub, the safety net hospital in Houston. He's a prolific author, including, in 2023, the book titled The People's Hospital, Hope and Peril in American Medicine. Writing from his experiences as a doctor in a safety net hospital in Texas, perhaps it is almost predetermined that much of his writing focuses on health disparities or how policies affect real people, but also the interface between art and medicine. And he's written for, those of us who are academics now may view with jealousy, things like Texas Monthly, the New York Times Sunday Review, theatlantic.com, as well as the New England Journal of Medicine. And his short stories have appeared in Best American Short Stories Anthology, McSweeney's, and other literary magazines. The New England Review published one of his short stories and awarded him its first Emerging Writers Award. He also directs the Human Expression and Arts Lab, HEAL, at Baylor College of Medicine, which is a lab that develops educational materials and experiences that weave the arts and humanities into medical education. And today, Dr. Nuila will take us inside the Harris Health System, which is Harris County, Houston's publicly funded healthcare system, to answer the question of where an uninsured person goes when turned away by hospitals, clinics, and doctors. Without further ado, welcome, Dr. Nuila.
Thank you so much for that introduction, Stephen, and thanks to everybody for being with us this afternoon, for this invitation. It's an incredible honor. I feel very much spiritually connected to New Orleans and Tulane for multiple reasons. My sister went to Tulane as an undergraduate. We've had multiple I remember during the Katrina, the Tulane students, medical students came to Baylor College of Medicine and did their rotations, and there was this just union of like these two institutions. Some of our biggest icons at the school, like Dr. Michael DeBakey, hail from Tulane University. So there's a natural kinship there. This is one of the reasons why I feel so honored to give this lecture. And it's not going to be as much of a lecture as much of a testimony, I would say, in the spirit of this lecture, of its search for spirituality and the connection between spirituality and medicine, which is that this testimony is how I have derived the meaning from the work in a public healthcare system in Houston, Texas. Now there are objectives. We are going to we're going to recognize the difference between public and non-profit and for-profit hospitals. We'll talk about Anton Chekhov, delineate the relationship between a patient's health insurance coverage, acuity illness, and type of treatment received. But the structure for this talk is that I will be reading segments of this book as pegs so that we can have this greater understanding of the connection of community and healthcare, public healthcare, how in our world of United States healthcare that it might offer a solution for some of our biggest problems, which are health inequities and the cost of healthcare. And I just want to note that from the very beginning, this is the only graph that you'll see. The rest of these slides are going to be watercolor images taken from photos taken from the hospital that were turned into watercolors that go with the readings. But this is a graph from the New England Journal of Medicine article that was in October 2024 showing the failing U.S. health system. And I just thought this was a really indicative graph because it shows how much of an outlier we are in both regards when it comes to healthcare spending and health system performance. Now, the way that they measured health system performance was multiple measures, including looking at access to care, but also availability of technology. A lot of things that one would think that any person who is living in a country would require or want from a healthcare system. And you can see that the performance for the United States is extremely low compared to other countries with similar GDP. And the healthcare spending is way, way, way out of proportion also. I don't think that these two axes, when it comes to the United States, my assertion is that the performance is low because the spending is high. And I think that that is one of the reasons, one of the lessons to take from public health care. And we'll go a little bit more into that. But for right now, I'd like to introduce you to the place where I work, Ben Taub Hospital. I'll just start reading from the beginning of the book, just to give you this introduction to this location. The rumor we heard was that patients arrived with hand-drawn maps. Our hospital marked like treasure. The stately Nigerian lady who responded, "Yes, doctor," to everything, metastatic breast cancer. The boy with the black curly hair wearing red Converse All-Stars and a Judas Priest t-shirt that screamed Mexico City, acute lymphocytic leukemia. The grandmother with the sari snagged into guardrails, chest pain, real chest pain, might need bypass. We stood at these patients' bedsides. We wrote down their histories. We said we were sorry for examining them with cold hands. We ordered blood tests, interpreted EKGs, scrolled through their CAT scans. We input diagnoses. We weren't just doctors. Among us were nurses, social workers, x-ray techs, the people who rode up and down the hallways in the middle of the night, waxing the floors. Some of us wore white coats with frayed sleeves and busted pockets, others tight-fitting scrubs embroidered with our names. In our bad moments, we became tribal. We weren't we. We were ortho, medicine, plastics, the 4A nurses. We only covered the unit. More often, though, the needs of our patients were so damn immediate, we found a way to work as one. We ran blood transfusions, heparin drips, a morphine pump when Norco didn't touch the pain. When COVID came, we gave oxygen together, one of us twisting the knob on the valve while the other inserted those tiny prongs into flared nostrils. We consulted one another when things looked dicey, surgery if we found boils, ID for antibiotics. And if anything looked remotely like a seizure, a twitch, a rolling of the eyes, we paged neurology overhead. If transportation was swamped, we wheeled them ourselves to MRI, to special procedures, to the cath lab, even the ICU. How downtrodden we looked when we did this, like beaten dogs. We figured out ways to make things work. Not enough money for your meds? We Googled the $4 list at Walmart. Muscles too weak? We dug up a refurbished rocker from the basement. Dying and homeless and alone? We called in a favor from the hospice that used to be a Tudor-style home. And when our work was done, once we could envision someone not dying within 24 hours of our discharge order, once the first chemo had gone in, once we could be sure their chief complaint was addressed, the thoughts still lingered in our minds. What brought them here? What are their stories? Ben Taub Hospital, the largest safety net hospital in one of America's most diverse cities. We are Heathrow if you replaced the Emirates and the Virgin Atlantic planes with Greyhound buses. There are no atriums with pianists here playing Here Comes the Sun to welcome you. No soothing sounds of running water from hidden speakers or gasp from an actual indoor waterfall. There is no Starbucks. Our cafeteria serves some form of barbecue most days for lunch and packaged salads topped with eggs or chicken strips. That's unless you prefer the full menu McDonald's located inside the hospital that's open 23 hours a day. We do have a gift shop, though it looks more like a convenience store, heavily stocked with greeting cards. Not the pun-filled ones, rather, the kind that get the point across. Condolences, available in Spanish, too. If you type Ben Taub into Google Maps, you'll find it crammed between the Houston Zoo and the 30 other institutions that make up the Texas Medical Center, the largest concentration of medical facilities in the world. Some of the field's most important innovations took place in this medical metropolis. The first successful bypass, the first artificial heart transplant, the first beatless artificial heart. Imagine that. No love dub, just a constant worrying. The first silicone breast implant, one of the first civilian helicopter ambulances, the Bubble Boy, all here. Not that the patients at Ben Taub know this. Some may have heard that MD Anderson is rated top in the country in cancer care, or that at Houston Methodist, you might find yourself fortunate enough to have a robot operate on your prostate. The TV ads air in Spanish, too. It's possible that at night our patients look out their windows and behold the sparkle of so many new glass buildings, some of them named after billionaire sheiks who sell the oil that becomes their gas. More likely, they're looking out in the direction of the zoo, toward the parking garage and bus stop, wondering how they'll get home. So like Stephen, I grew up in Houston, and I didn't know what Ben Taub Hospital was. In fact, my only knowledge about this location was when I was going in my car to school. My dad was dropping me off, and he had his radio station on. It was AM radio, and you might hear the news of a crash or some sort of trauma incident or violence, and the phrase would be crews on the scene, like the victims have been taken to Ben Taub. And that was always sort of a different place for me. It was just not something that I encountered. Now, what I've learned since going to medical school and learning at Ben Taub, and also staying on as faculty for the last 15 years, that American healthcare has changed since that time that I was listening to the radio in my dad's car. And that what used to be the case of just really a location, a public hospital being the location for trauma, is become more of a location for people who don't fit into our insurance-oriented healthcare system. And those people who don't fit into that healthcare system is a growing and changing dynamic population. It's not what you would conceive of. People, all Americans, all of us are standing on ice when it comes to our healthcare. Now, some of us are fortunate enough to have thicker layers of ice beneath us, but it only takes a few critical diagnoses because of the cost of healthcare, because of that exorbitant cost that we saw at the first graph, that because of that, that we are all on ice and we can all fall through that ice. And where do we go when a nonprofit hospital or for-profit hospitals who don't necessarily have to provide health care for people who do not have remuneration like insurance? Where do we go? Well, in Houston, Texas, that is a public healthcare system founded by property tax and city government funding. So I want to introduce you to one of those people, one of those patients who learned about this, who learned about what Bentob was and under different circumstances. If Stephen Hart was good at one thing, it was managing restaurants. For 12 years, he'd resurrected different branches of a burger chain in Houston and made them profitable. Stephen didn't have an MBA or any kind of special training. He had people skills, which, after some twists and turns in life, had bloomed for him in the service industry. The truth was that Stephen enjoyed going out of his way to help customers. He loved becoming the highlight of someone's day. That corporate talk about turning an ow into a wow sounded lame, yes, but in fact, it made him tick. He wasn't one of those general managers who buried himself in an office tracking avocado prices during the dinner rush. Rather, he preferred striking up conversations with customers the moment they stepped through the door. One night, while Stephen was taking orders at the counter, a guest mused to him about having eaten the tastiest burger there the last time he came, one with slabs of bacon and Swiss cheese topped with a thick slice of grilled pineapple. Did Stephen know the burger? That would be the Hawaiian burger, Stephen said, smoothing out the ends of his stash. His silvery voice and appearance, kempt, like a man rising from a barber's chair, helped to soften the bad news that the chain hadn't carried the burger for years. Man, the guest lamented. Most general managers would have chalked up the disappointment to part of the job. Specialty burgers came and they went. Stephen, however, was not most managers. Would you like one? He asked. That would be awesome. Stephen warned him it might take a minute, since he knew the kitchen didn't stock pineapple. He picked up the keys to his truck, exited the restaurant, and drove 3 miles to the nearest grocery store where, for 89 cents, he purchased a can of the prized fruit. Not 10 minutes later, the first dribbles of nectar sizzled on the grill. Stephen made sure the char was just right before flipping the pineapple over and then crowning his concoction. As the guest bit into his Hawaiian burger, Stephen knew he'd earned a customer for life. So this is Stephen. He is not what you think of as a Bentob patient because he's employed. He is a person who has who makes $75,000 a year managing restaurants. But he is going to find out a lesson about American life, which is that he is on a layer of ice, just like all of us. The burger chain had different grades of health insurance, from Cadillac plans to the bare bones. Ever a bargain hunter, Stephen opted for the cheapest health insurance available, which deducted only $88 from his check every other week. Like buying cheese at the right price point, this was a value-based decision. In his 55 years of living on God's green earth, he had never needed to see a doctor. Why waste the money? Then in late March 2020, as the world awakened to the fact that a pandemic was spreading to all its far corners, Stephen phoned corporate with some bad news. After shaking all night with chills, he checked his temperature. Stephen was running a fever. As the only one with keys to a restaurant trying to make do during a COVID lockdown, Stephen knew this presented a problem. He agreed to open the restaurant and return home immediately for a 2-week quarantine. This would be the last time he set foot in the restaurant as its general manager. His insurance plan only provided coverage for a teledoc visit. Via his webcam, Stephen tried to show this new doctor a lymph node below his left jaw, one that had grown in size over the past year. But Zoom made it hard. The doctor prescribed him an antibiotic, and within a couple of days, what it felt like a pea beneath his skin now felt like a baseball. Stephen was sure he didn't have COVID, and he began to worry the mask was causing the fever. Aware it would cost him, Stephen decided to bite the bullet and visit the emergency room of a reputable nearby hospital. Before even sitting down in the waiting area, he paid the $639 requested, insisted upon by the hospital's clerk. This got him in the door. Next, a doctor examined him, ordered a CAT scan of his neck, and not long afterward, relayed the results. First, that Stephen had cancer in his tonsils, and second, that an ear, nose, throat doctor, or ENT, awaited him at a different branch across town. Stephen feared what the ambulance ride might cost. I feel okay, he said. I can walk. Can't I just drive myself or go tomorrow? The hospital followed a specific protocol in these situations, the ER doctor explained. Stephen walked into the ambulance and sat quietly the entire ride to the branch. Once they arrived, nobody there seemed to know anything about his situation. So Stephen waited patiently for the ENT who was supposedly there waiting for him. Finally, after many hours, the doctor saw him. He'd seen the scans and, yes, there appeared to be cancer in his tonsils. Stephen expected more after this, for the ENT to say, and so, or based on this, or to dive into some plan of action. This was cancer after all. But the operative word was, however. However, you don't have insurance, he said. He meant sufficient insurance. It is a fiction in America that the thin plastic card bearing our name and plan is our panacea. Politicians and journalists pretend it's a tidy little equation. If you're insured, you're okay. The truth is much more complicated. Even though Stephen had insurance, it covered so little that he had to prepay the ER for a cancer diagnosis. He could live with being on the wrong end of a bad deal, for now anyway. What he couldn't quite digest was how the people in the ER had treated him. He felt shitty. It seemed wrong that they'd sent him here and there and then kicked him to the curb. He could understand that nothing would take the cancer away today and that his life wasn't immediately in danger. But how can anyone be so callous? Who says, however, in a situation like this? After the ENT departed, a social worker entered his ER room and gave Stephen some quick and simple advice. Go to the public hospital, she said. Go to Ben Taub. Stephen patted the tiny handlebar ends of his mustache. His fingers drifted to the left side of his neck, which felt hard and unshaven. In his mind, these two words, public and hospital, never belonged together. Wasn't this America? He'd never spent a night in a hospital, and now he would have to step foot in a place he recognized from the 10 o'clock news, where gunshot victims recuperated and Houston's homeless took shelter. He imagined drug addicts lining the halls, the dregs of society. This is going to be hell, he thought. I have hit bottom. So that is Stephen's introduction to the healthcare system. He hadn't really had to access healthcare before, and that's one of the real marks of American healthcare is that that graph, I think, encapsulates that, is that the costs make it so that there's inequality. And he goes to a hospital, a nonprofit hospital at first, one that receives tax benefits in order to provide care for people who can't afford it. But because of the way that this is regulated and the demonstrations of what nonprofits have to show, it's not necessary. They don't have to care for him. He's going to find out what it is. He has these concerns about what a public hospital might look like, and he's going to in the course of this book he's going to visit Ben Taub, and we'll see how his course goes through it. Now that's his introduction to Ben Taub Hospital and healthcare. I want to kind of take a step back and give you a little sense of what my introduction to healthcare was like, which is very, very different. I'll just dive into that right now. When I started working at Bentab, I didn't know what it meant that most of our patients had no health insurance. Growing up, I experienced healthcare the way most people in this country do, which is through private insurance. My pediatricians encountered no snags as they kept me on the vaccine schedule and ensured I didn't fall too far off the growth curve. The doctor-patient relationship looked idyllic from my vantage point. My dad delivered babies for a living, and every Saturday morning, he brought me to the hospital for his rounds. I was my most docile self during our short car rides, which ended in the parking garage. From there, it was a couple of quick turns in the back entrances and service elevators before we were on the labor and delivery floor. This is my son, he'd tell the L&D nurses. Yes, yes, we've met, they would respond graciously. After the intros, my dad would punch a couple of numbers into an electronic keypad to open a door down the hall. And for the rest of the morning, I parked myself in front of the television in the doctor's lounge, where I watched TV while he visited his patients inside the hospital. It was glorious. Being at the hospital made me feel fortunate, like my dad's assistant. Aesthetically, the lounge could have used a little love. Every table or countertop had granules of sugar speckled over it, and, of course, the heavy aroma of burned coffee hung in the air. I spent hours in there. Sometimes his doctor friends would come in, sit down, and make me chat to them about my family and school. Other times they'd see me presiding over the TV and leave as quickly as they came in. These Saturdays with my father started in America's heartland, Wichita, Kansas, where my dad worked for a private clinic owned by a group of doctors. The clinic used the hospital we visited for all its deliveries, which was how my dad had his special standing. Having joined the group fresh out of his residency, and less than 5 years after immigrating from El Salvador, he worked overtime the way a young lawyer working their way up in a firm might. The established partners gave him a base salary plus incentives for productivity. His schedule included plenty of overnight calls and undesirable shifts, though my dad never complained much. It must have helped that he was young, but my dad also saw his work as a doctor as more than just a job. Medicine was his calling. Those scrubs in the OR and that suit in his clinic were his identity. To my dad, the privilege of talking with people about their problems and thinking about and sometimes operating on them was priceless. The partner set all the rules for the patients he saw and the payments he received. My dad didn't have to do anything but work. Estoy de turno, I'm on call, became a common refrain around the house. So that was my dad's circumstance and experience of healthcare at the beginning in the mid 80s, was that you could start a private practice and you could practice medicine the way you wanted. And I remembered going to his office, and he would have this ritual where he would introduce new patient would come, and they would sit in his office with this desk, and they would have a conversation before doing anything, before an examination. And that's one of the reasons that drew me to medicine. I saw that very much in my father. I saw he loved his job. I saw the pride that he had, that it was a calling, and I naturally kind of gravitated toward it. But something changed between mid 1980s and the time when I was applying to medical school in the late 1990s. I had applied to medical school, but I was reticent to go, and the quality of the experiences that I saw in my father had changed. He had that ritual that I told you about, but when I went to visit his offices toward the time that I was applying for medical school, that office that he used for getting to know patients, it was manila folders stacked. There was no place for patients to sit. he started his practice in the 1980s with three employees: a nurse, a um, a nurse, a receptionist, and him. But by the time that I was applying for medical school in the 1990s, he had multiple employees, but he had three that were full-time, dedicated fully to insurance claims, health insurance claims. One of them was my grandmother, his mother, who he employed for that. She's Chicago-born, Depression era race, kind of the best person in the world to have on insurance companies, really, because won't quit. But still, it was this world had changed, and there was policy reasons for why that happened. At that moment, what's happening is actually that there is this vertical integration of corporations taking over American healthcare. They're buying they're buying insurance companies, they're buying or they started as insurance companies and they're buying hospitals and they're buying doctors' practices, and they're aligning those interests so that it's clear that if you are in control of the labor, which is doctors, you can assure that those consultations and the references go to your own hospitals. And if you're trying to cut costs, you're trying to make it the coding difficult so that people can't recuperate. That's all happening at this time to make the delta between when I was seeing my father to the time when when I was applying to medical school. That was the major change, that it had become overburdened by administration, overburdened by this effort by corporations to squeeze out every dollar in every way, and we're seeing it manifest in the way that doctors practice. Now, I ended up going to medical school. I was very reticent. I was thinking I want to do something else about it, but I had gone my whole life to it. And what I can tell you is that Bentop Hospital was really one of the reasons why I stayed in medicine, because there just wasn't this drive to eke out every dollar from every healthcare experience. I saw shades of what my father had in the 1980s, this closeness to patients. I was a learner, and I know that there were other pressures going on, and we still live with a lot of those pressures, but at least there was something about that relationship between the doctor and the patient that was not overburdened by finances and by healthcare. We were there, and I was there as a learner and then as a faculty, but there was policies in order to make sure that I wasn't taking every ounce of that time with patients and trying to monetize or make it the financialization of medicine. And I attribute and after doing research, thinking about it, talking, and I think that this happened over many years. I think that the mission driven, the paying, the system which is not geared toward producing profit, really allowed me to connect with those patients. Okay. The tension between what is public and what is private is fundamental to the hospital. We arrive at our weakest and most vulnerable. We present ourselves before authority figures clad in scrubs and give our arm for a vital sign check, our tongue to see if we have a fever, our insurance card if we're lucky enough to have one. We give our words, the histories of our health, our rendition of the events that brought us there. And then we wait. We wait among others. We absorb things from these strangers, not their contagion, but their body's instrumentation of it. We hear wheezes, dry heaves, muffled sobs. We see yellow skin and black bruises and the spectacle of human organs in conflict with themselves. We smell the dehydration of others, the sweet ketones in their breath, their sweat and bile. And still we wait. From now until we are discharged, we are the hospital's wards. When finally it's our turn, we find ourselves led to a stretcher cordoned off by a sliding glass door, a wraparound curtain, perhaps even drywall and a door. We think we're better off like this. We believe this privacy constitutes more personal care, and we certainly pay more for it. But are we really better off? We are no longer with so many strangers, but we are no longer in view of the nurses and doctors either. How much privacy is appropriate in hospitals? Over the last 100 years, the architecture of emergency rooms and medical wards has changed to make care more private. Originally, 100% of the hospital beds were laid out in large wards where patients lay side by side. But by 1910, that number had dwindled to 28%. As the care of the wealthy migrated from their homes to private rooms and hospitals, the large communal wards began to disappear. And that's something that I had to reconcile. Like, I appreciated the connection that I had with patients at Bentov Hospital, in the public hospital, but I had to reconcile that it looked different from other hospitals. This is a depiction of how close the beds were in the emergency room, in the wards where I was training. And so, you know, as much as I felt, wow, like this is like, I can actually do a good job here. I can actually, I am not geared toward like the insurance claims that are drowning my father's practice. I can just, you know, focus on medicine and the patient here. If you take a step back, you realize, well, like, but what is this? Is this, why is it so different? Is the place where I'm working at fault for for why it looks like that? And, you know, I think, you know, today, if you went into Bentov, you would not see this. The emergency room has been reshaped. Private bays in the emergency room. There's still, but we are still dealing with overflow, and there's still patients in the hallways. We're chasing our tail a lot, and much of that reason is because of health inequities. Is that when we are not able to have people trust in the healthcare system so that they start off with preventive medicine, when we have a focus on health care rather than health, then we have a problem where it incentivizes so much for it incentivizes procedures, it incentivizes acute care rather than preventive care. And I think that the county hospital where I work, the public hospital, is a manifestation of the outcomes, the consequences of that. But I do think also that the public nature of it has some benefits too that I want to go through real quickly. I must acknowledge that my position on the open ward was a privileged one. This is true of all caretakers. Bentov's open ward allowed me to stand back and observe all of my patients' activities as if they were a TV show. I had only a small protected role to play in the drama that unfolded in the Nightingale ward. If I were the one lying on the stretcher connected to electrodes, waiting for CAT scan results, I have no clue how I'd handle myself amid the shouting and the retching and the flashes of nudity. On one hand, I suspect I'd want to make sure the medical staff had the best chance of assessing me. In that case, I might wait patiently in an open ward. On the other, I would probably want privacy if my illness made me feel vulnerable. Some of my patients have told me that their time waiting in the Nightingale ward changed their lives. God wanted me to see it, one patient said to me. She described herself as middle class and lived in a wealthy suburb named Sugarland. She'd never thought she'd come to Bentov as she'd had health insurance most of her life. But divorce left her uncovered, and that was exactly when she got sick. All of her friends told her to come to Bentov. She waited in the ER for many hours, desperate to figure out why she was losing weight and feeling tired. As she waited, the drama of other lives unfolded in front of her. She saw prisoners and people in the throes of psychoses, all from different social classes, trying to cope with their own problems, and she found it transformative. Seeing that pushed me out of my bubble, she said. Bubble, I thought when she said this. The word reminded me of a quote from philosopher John Stuart Mill. One of the effects of civilization, not to say one of the ingredients of it, is that the spectacle and even the very idea of pain is more and more kept out of the sight of those classes who enjoy in their fullness the benefits of civilization. Patients tell me they commiserate in the Nightingale Ward, that they build solidarity. Sometimes the best kind of healing happens there. Another patient told me she never wanted to wait the way she did in the holding area again. The only saving moment, she told me, was her conversation with the man next to her. He was recovering from a crack binge. He was sobbing at the state of everything, how his life was in ruins. The woman was a recovering crack addict and had been totally drug-free for going on 10 years. She told me she sang a hymn with the man, tongue-lashed him a bit. You're the only one that can stop. Told him exactly what she'd done to quit and prayed with him. Without a doubt, none of us working at Ben Taub that day had been as helpful to the man as she had been. And I think that that's what I wanted to kind of hone in on in the spirit of this lecture, the spirituality connection, is that there is, I think that community can bring about this spirituality. Community is seeing resilience in people coming together, helping one another. I mean, I find that at a public institution that is mission driven and that people know that this is the community, the taxes from the community, paying for people in the community. This is a testimony of like how people experience that even in very hard circumstances, like in the holding area. Now, I also think that like some of like the best ideas come from this idea of community. The whole genesis of the idea of the hospital system, of this local healthcare system, I attribute to somebody who was a really profound thinker and an incredible person in the 1960s named John de Hartog. Now, John de Hartog was a novel. This resume will blow you away. This person was a Nazi resistance fighter, Dutch ship captain who captained ships to help people in the floods, but also a novelist and prolific playwright who, in a very Houston way, found himself in Houston. I don't know how, but he did. He was teaching at the University of Houston creative writing. And he's a Quaker, but he was also a Quaker. And part of his faith was volunteering in the community. That's very important to his faith. And when he arrived in Houston in 1965, or in 1963, he found there were rumors going around in the city and the parties that he went to for the academic parties and whatnot. They talked about the hospital in town, the public hospital in town, the only one that people could go to if they couldn't afford healthcare. It's called Jefferson Davis Hospital. Now, at that time, it was African Americans and immigrants who utilized the public hospital by and large. And at the whisper is in these parties was how atrocious the conditions had become. It was about this children, like the rumors were that there were children who cried throughout the night because there was no milk to give them at this hospital. That there had been deaths in the maternity ward from staph infections roiling through it. That people sat in their own filth for hours, people who had broken legs and they couldn't move, and because there was just such short staffing. And de Hartog, with all of his experiences, said, that's exactly where I want to go. So he trained himself as an orderly, went to Jefferson Davis Hospital, and it was exactly as people had said, possibly even worse, that people were not treated in the human way that he thought. Like, this is a person who had seen really terrible things throughout his life, and this was tantamount to that. And so he wrote op-eds about it. He wrote essays that appeared in the Houston Chronicle, Houston Post. He amalgamated them to this book called The Hospital, and it became a political issue, a civic issue, because this resonated with the Houstonians at the time. This resonated it resonated also with the business community, because the national headlines or the international headlines would say, Houston is building a stadium, the Astrodome, the first indoor type stadium like that, but cannot take care of poor patients. Houston was really on the forefront of people's minds because it was a Cold War city because of space race. This was like we can't really imagine today how important the Cold War was in all the thoughts of people at that time. And so, Houston was the city of the future. And what he did was bring this as an issue to make it a civic issue, and people eventually voted in favor of the public healthcare system to have local taxes create a place that is higher standard. And that's the seed that plants the seed for these hospitals and this healthcare system that provides specialty care, primary care that I work in today. So I want to just show you a little bit about, I hope that this video plays, but this is an old video of John de Hartog talking about this. This is from the Walter Cronkite show in the 1960s.
Texas Medical Center is a unique collection of 16 hospitals, clinics, medical libraries, teaching, and research institutions. Baylor University Medical School, which pioneered open heart surgery, moved to the center from Dallas. Various institutions here are busy with space medicine research for NASA. The center, built with the help of rich Houstonians, receives support from such sources as the Heart Fund, the National Cancer Institute, the federal government. The University of Houston has 17,000 students, has recently added space-oriented courses tailored to NASA needs. Today, young Texans are studying the composition of the moon and the planets. Peter Poore talks with Jan de Hartog.
What do you like most about the city? One thing.
I like about the city the creative excitement in the air. And that I don't know how else to describe it. And it is wherever you go, wherever you look, it's there. It is a city of not only one feels unlimited possibilities, but it is also a city of unlimited opportunities. It's an immensely exciting town, and you feel that anything is possible. Anything in any sense. You can have the biggest theater, the biggest stadium, but you can also have the biggest and the best charity hospital in the world. You see what I mean? It is not just the material possibilities, but also the civic and the spiritual possibilities are unlimited.
What do you most dislike about the town? Do you think is its worst feature?
The climate. It's the climate of Calcutta. And the British embassy gives hardship money to its members. And I think they're right. It's a terrible climate. Now it's fine, but, come in the early summer and you'll broil.
I had to, as a good Houstonian, I have to rip on our city's, weather at all times, and which New Orleans shares. We're very akin in that, in some regards to that. But I really love his placing that the charity hospital. Now, at that time, charity means something different than what it means now. But at that time, what he's talking about is a hospital where where people who can't afford healthcare can actually get treated like human beings. He puts that alongside all of the dreams, and it's a spiritual dream that he has. And I believe that it's inspirational. And I think that when I work at the public hospital and I see people receive treatments that you would not think that they would receive, chemotherapies, surgeries, all TAVRs, things that that the standard is being applied for everybody. It heartens me, and it inspires me, and I think that there's a lot of that from Mr. de Hartog. I'm going to end with one other person who's inspired me, and that is Anton Chekhov, who had similar ideas. And I'm just going to dive right into it, and then we will be done. And I know I'm running a little bit behind, but we will go there. There ought to be a man with a hammer behind the door of every happy man, Anton Chekhov wrote, to remind him by his constant knocks that there are unhappy people. Many people know Chekhov worked as a doctor, even as he wrote his short stories and plays in 19th century Russia, but his devotion to the poor is not so well recognized. Chekhov traveled via horse-drawn carriage from Moscow, which is on Israel's longitude, 3 months through the Russian tundra, nearly 4,000 miles, to Sakhalin Island, just north of Japan. He did this to write about the deplorable conditions of a penal colony on Sakhalin, as well as the public health failures. More than anything, however, Chekhov wrote about the people living in these desperate conditions. As famous as he was, Chekhov could have worked as a concierge doctor and catered to Moscow's elite. Instead, he wrote stories about the poor so that the fortunate might understand that their plight is everyone's responsibility. Apparently, a happy man only feels so because the unhappy bear their burden in silence, he wrote. Chekhov eventually died of tuberculosis, an illness he contracted from the patients he served. He had been born poor. His patients were poor. He had traveled to the poorest part of Russia. He saw in his practice how tuberculosis devastated his fellow Russians, with a mortality rate of 400 deaths per 100,000 people, 1.5 times that of COVID-19 in the United States more than a century later. Chekhov also recognized how little the government of his beloved Russia cared about tuberculosis and poverty. The authorities had enacted a campaign they called the Fight Against Tuberculosis, which consisted of nothing more than epidemiological surveys. For all its pomp, the program received no funding from the state. Rather, it relied on charity. This touched a nerve with Chekhov, and 3 months after returning from Sakhalin, he wrote a letter to the vice director of the Ministry of Justice, a man who taught law, served as a judge, and, it so happened, had a soft spot for writers. I believe it is very harmful to have to depend mainly on charity, he wrote. I think it would be far better if this problem were to be addressed by funding from the state. Chekhov explained that the problems of Sakhalin went deeper than whatever numbers might appear on a survey. I encountered no infectious diseases in Sakhalin and found very little congenital syphilis. But I did see children who were blind, dirty, and covered in sores, all diseases that bear witness to neglect. Years later, at the height of his popularity, Chekhov sat down in the dining room of the Hermitage restaurant, one of the most exclusive locations in all of Russia. As the meal began, blood began to stream from his mouth. The tuberculosis, which up to that point had for him been more of an annoyance than a debilitating illness, had caused his lungs to hemorrhage. He lay in bed for days recovering, first at a clinic and then at a hotel. The clinician and master of the written word received what treatments were available, including ventilated air spiked with turpentine and eucalyptus, wine from Hungary, a cognac after dinner. He wrote more letters in his convalescence, including to young authors, giving them advice. Your task is to be a sincere artist, writing only about what exists or what you think ought to exist, he wrote, painting pictures of life as it is. And that's what I think is important about what the Hartogs does, Chekhov does, what we can take from it is like we should be working toward what ought to exist. And what ought to exist is a graph where the United States is closer to its companion countries, where the costs are not so high, where the quality is high, and it's for everybody. And I believe we can get there. And I believe that the healthcare system provides us with clues. The healthcare system in Houston provides us with clues on how to get there. Public, community, ideas, relying on community and localizing it, but also drawing a line for standards and making sure that everybody in the community receives this access. So I will stop there. I appreciate it. I know that we've gone a little bit over, but I appreciate all of your attention and thank you again for the invitation.
Oh, my goodness, thank you so very, very much. And I'm happy to stay as long as people are able to. If, with your permission, I will just start asking questions from the Q&A, and anybody who has questions, please put them in the Q&A. We'll just go in order here. Concerning your first graph, because you came right back to it, and only graph, and the ideas and implications this represents, I'm wondering if the U.S. healthcare system is looking at the wrong variables, right? Could there be a different set of variables that would put the United States, are we cherry picking, maybe is the question?
Yeah, I mean, this came from the Commonwealth Fund like study, which is looks at multiple health, absolutely. We could derive a graph that said like what, you know, how large is a healthcare one of the factors is how many jobs does healthcare industry create, and the United States would be a huge part. This one, the Commonwealth Fund, which study takes five different sort of uh, factors, and around three of them have to do with two and a half have to do with like healthcare accessibility to everybody. So for certainly, if that's not one of your values, then you wouldn't want to derive that. But you wouldn't want to utilize that as a factor. But some of them are really about also like the use of technology and limiting administration and everything. And it's still very much so that the United States, and it's hard to find studies that show how good, like, for certainly the United States does very well for some people. People travel to the United States, and that's like the big concern is like if we spread this out, do we decrease the technology impetus so that we are like not going to be able to make advances? But I'd like to push back on that a bit because I think that we can walk and chew gum at the same time when it comes to this. It's a matter of what are our prioritizations and alignments and the way that things have been structured. And unfortunately, the healthcare system has not been constructed. It's patchwork. There was not a moment in history that they said we're going to build a healthcare system to achieve these goals. This has been something that has been the effect of like it's grown to have these incentives based on some of the problems that it's felt, but not like other policies has there been like the thoughtful, like let's have some values, let's to achieve these values, let's do it like this. It's not, it's just been patchwork. Like the major one, Medicare and Medicaid, happened because it was not like it wasn't a part of a whole larger idea of like we have to build a system. It's more that the problem was that there were so many people who were ill that were not receiving care, that were overburdening hospitals and doctors at the time, that these insurances were created, federally funded insurances. So I agree with you that you can like that the Commonwealth Fund decided to pick these factors. They have rationale for them. I think that it's also something to think about, and think about by that rationale, we're still way behind. And some of those countries are quite different. It's not like they're all so politically close that we can say, well, it's just purely our politics. It's a matter of like how we implement our policies also.
Thank you. Someone, David Oxman says, came in late and maybe you explained, and I think you did, but just for him and maybe others, who does your illustrations? Could you repeat?
Oh yes, that's Danica Novgorodov. So I worked with her when I wrote an article for a literary magazine called Virginia Quarterly Review, and she did the illustrations for that. And so I worked for the lectures that I give. I just wanted to use her illustrations. I think they're beautiful. She's an artist. She's a very well kind of like known watercolor artist, and she was very gracious enough to convert some of these photos into watercolors. And I'll give you a kind of like the reason that the literary magazine used the watercolors was to assure that there wasn't any privacy violations, because if it's a photograph, it's a little bit easier. Like people can have like a bigger problem with privacy rather than like watercolor images like this. So I thought that's also kind of an interesting kind of overlap between art and medicine in that regard,
So question notes that, of course, healthcare system decisions are both political and deeply moral. And so I'll just read it straight out. How can people be okay with the concept of a charity hospital when healthcare is a human right and everyone should receive equal or equitable care? Of course, we all end up paying with our taxes and don't realize it, but never mind
Right.
that. How can we accept this?
Yeah, I think that's a great question. I think that's what that's why I tried to kind of talk about, like, when we hear the word charity, the hard talk thinks something else. But I do think that Chekhov was also like, this is not something that belongs to charity. You know, this is something that is like a foundation of a good society. And I agree with you. How do we? I think it. You know, I go into it in the book of like the history of that notion. Some of it has to do with like just like an ingrained sort of idea that people have to earn their health care. People that if you go back to the 1700s and 1800s, that people were seen to be, you know, responsible for their health care, because if you saw if somebody with like alcoholism, that person was deemed unworthy for healthcare, because at the time there was voluntary hospitals and they had to make decisions on who the patients would be at their, because they would basically be volunteering for their small communities. And this concept of, well, if we have a hospital bed for somebody who is if we have one bed and there's like three people out there, how do we decide who? They use moral valuation like that. And some of that, it was because there was just no health care. There was not a baseline health care. Now, I would argue that we're in a wealthy society now that can afford a lot of things. We should be extending health care for everybody as like a basic, you know, it's truly, to me, it's a utility for society, you know. And so I think that, but I think it's been bogged down by these ideas of responsibility, of personal responsibility and worthiness that you can trace to the 1700s and 1800s and the way that voluntary hospitals operated.
Do you have any suggestions as to how we might galvanize our colleagues, physician and otherwise, who may be unwilling to speak out in an organized manner to shift focus from money making to good care?
Yeah, it's a great question. I mean, I like probably so many people were stunned by the assassination of the United Healthcare CEO for a lot of reasons. It's a murder, but I was also shocked that how hearing people's response to something like this and saying like, I have suffered because of like the way that healthcare industry has treated me, and just the sense that people are feel powerless, that this is the only thing that can, it's gotten to the point where the only thing that can be done is violence. It's scary for me. And it made me you know, and so it's I have it's it I think we're at a critical moment. I really believe that we're in a critical moment where people really have lost trust in a lot of establishments. And that, so to answer your question, I had said before that incident, I'd said like, this has to be done democratically. This has to be done like at a local level. I think that the model that what John DeHartog did for Houston really resonates with me, is that like, can we start kind of from the grassroots and build up from that? And now I think we do need to unify as people who are in healthcare profession, and really kind of have like stake out the values of a system and say, this is what a system ought to be aiming for patients, not for profits. And we start with the profession of those values, and we agree to them, and then we build from there. And I think that that's really important, because it's just not been said. It's not really been agreed to. And that's hard. I'm not saying that any of this is easy, but I feel like that's we like, there is such a sense that there is like that we're powerless with regard to these corporate powers that have overcome, that that I do think that like a profession like that having like values that we all agree, like what are we aiming for? Let's build it, and then starting democratically is like really an essential thing that like I think that could help out.
So many good questions. I want to ask all of them. Um, so let me try to blend a couple of them. What are the political challenges to maintaining funding for Bentob, and how do you keep it a priority in the city of Houston, especially in the context of federal moves towards promoting Medicare Advantage to replace traditional Medicare, which seems like it would accelerate the problems.
Right.
And and then I'll throw this in, even though I recognize it's a separate issue. And then how do you continue practicing in a post-Roe or post-Dobbs world?
Great question.
Yeah.
Those are great questions. Well, one thing I will say is that we have actual more consensus about healthcare than we know. If you've done the polling suggests that actually around Democrats and Republicans, 70% of people think that the federal government has a role to play in healthcare, and that everybody should should have some level of basic healthcare accessibility, you know. And the reason I mentioned that is because I feel like in our last election at Harris Health, a year ago, there was an election, the first time since the inception of the Harris Health system in 1965, on the ballot was this question of whether we wanted to give $2.7 billion to rebuild LBJ Hospital, Bentob's sister hospital, and give more money to the health system. And it's the same politics, same, all of what you think about like politics in New Orleans or federally, it's like similar in Houston, meaning like there's still like loggerheads and concerns, but it passed by 75% to, there was like, it passed because people identified it as a true benefit to the city. And so I derived hope from that. I think that the way that you fight, that the politics is that you like, you do have to show value on both sides of the value. For possibly one political side is universality of care. The value for the other side is like, maybe like cost cutting possibly. And that's one of the things that I find such an interesting piece of where I work is that it achieves both of those. Everybody can get universal care, and it's also cheap compared to other places. And I think that this is one of the reasons why the healthcare system is so like of the United States that we experience is it's working against the consensus of most Americans. The consensus of most Americans really believe that everybody should be able to get cared for if they need it, and we shouldn't have to pay so much. So it just shows you that politics is a real major part of it. And the politics changes, like you noted, the politics changed very quickly in Texas with the post-Roe world. And I have to say, I mean, I'm an internist. I'm not an OB-GYN, but I've definitely seen in my OB-GYN colleagues that it's very difficult to practice with this changing. There's been like cases in Houston where women have died because of the way that the law hung over the doctors. The new law. They weren't like, there was one woman in Houston who ended up dying because she did not she had a the doctors did not know if it was legal for them to perform a abortion on a fetus that was already expired, dead, or however you want to say it. And she ended up having medical complications and dying. And the people who wrote the law said that the doctors misapplied it. So it just adds to the disheartening, the demoralizing kind of part of like that gets between you and your patient, which is that you want to be able to provide them with the best care. You realize that things are changing politically, and that the politics can be a part, can interfere with that, but you try to do the best you can, so but I do feel for many of my OB-GYN colleagues who have had to deal with that. My father no longer does OB. He's not really doing much. He's not really having to deal with this issue.
So multiple questions along the lines of, could a single payer system help address this? Why might it work? Why might it not work? Or perhaps, is there any talk about unionizing to address this?
Well, I think unionizing. So my like there's strength in numbers is one of the lessons in researching this book and reading the histories and everything. There's strength in numbers in looking at the policies. And just an example of that is Michigan, like where the state of Michigan, if you are a union worker in one of the automotive industries, you actually have good healthcare plans for your, like, because those unions really do negotiate great terms for their members, and costs can go lower for that reason. There's data to suggest that costs for healthcare in these places like Michigan, where there's like large, strong unions who negotiate on behalf of their members, do well for their members and lower costs. So my idea is just like, isn't the public healthcare system just like all of us in a union? You know what I mean? Like that is just like this is one of the reasons why I think I do believe that we need a healthcare system that is accessible to all, but I also think that we can't offer everything to everybody. That needs to be a real conversation. And we have a healthcare system that has incentivized doctors, potentially patients, everybody to obtain as much health care and as like procedures and everything as possible because of the money that it generates so that's a hard break to apply. That's a hard break to like push down upon, because there's so much momentum going in favor of doing more and more and more. But like I think that a system that we can call a basic healthcare system that's accessible for everybody, that people do not pay for, that everybody can get it, can revolutionize healthcare. And it can set the market. I think that if we have something like that, it can help reset a market that's a little bit more kind of not so heavily insurance reliant, and markets where people can determine what their costs are and everything. So that to me is like the major step that we need to undertake. So I'm sort of the person who's not necessarily for a single payer, but more for a single system. Um, there's differences. I would say like the NHS in the UK is a system that is paid for by the government, and so they own the labor, or they pay for the labor, and they own the hospitals, and they produce the drugs and everything like that. Versus a single payer, which is like Canada's, which is like the hospitals are all independent, but the Canadian government pays to cover all that. Now, the government will end up negotiating terms with these hospitals. They'll have to fall in line. But to me, I fall upon my own experience, which is in a system which is where you have a system that is owned by the local government and provides it. And I think that there's something I've liked that. And I also am a little bit skeptical about like a single. One of the lessons of history that I've seen in reading is that if there's a way to game the system, they'll find a way to game the system. And I think that that's one of the reasons why you control if you can provide a different means of production, you do that rather than like allow people to game the system. But that's my own opinion right there. That's.
I keep waiting for everybody to drop off, and we still have so many people. If you're willing to answer a few more
Yes, I'm
questions.
willing, because I know I went a little bit over. And
Yeah. I'm glad I went back up to this one. Appreciate the stories you shared about de Hartog and Chekhov, and interesting, they're both writers. What beliefs might they have had in common, and how do we support people who have this drive?
Well, I think this is supporting it. I mean, I think that this program that of human values, I think it's a beautiful name, but I think we're at a critical junction with regard to that, because I mean, yeah, I don't mean to sound like the old curmudgeon, but AI is basically we're trying to pay for thinking now. Where I think that thinking is essential to being a human being. And I think that like medicine is, I think that that's one of the values that they would share, Chekhov and de Hartog, is just like what the sacredness of being a human being, the sacredness of like the behaviors and the functioning of human beings, and paying heed to that, and using humans as our human beings, our resource and our priority, and rather than like going toward technology. I think that, I think we just forget that technology is a tool to help those interactions with people. But I define medicine as fundamentally human. I believe that what patients really want is another human being, because of the responsibility that another human being, that you cannot get that responsibility from a program. And the assumption of that responsibility means something. And I think that de Hartog and Chekhov would have thought similarly, because I think that they find connections between human beings as one of like the biggest treasures that we have, in one of the ways that we can build upon problems that we have in our society is through those connections, through those authentic connections that we drive. And those authentic connections are forged by study of humanities, understanding, history, and all the nuances that are presented in art, of the different shades of like how human beings are and what they think. So I'm a big believer in the humanities, as you can tell.
Do you have a use of you mentioned early, but do you have a use of spirituality in how you think about this?
I do, and it's like I have to say that I more feel it than I can like put it into words. It's I was raised Catholic and went to Jesuit schools, and I had a very that had a huge imprint on my identity. The Jesuit schools, and it's still to this day, like the idea of social justice, but also, I think that the humanities, and the love of like the humanities, much of it comes from that education. And but I also, it's like, we're in a world where we can see all like as many of the world today almost like prioritizes some of the negatives before some of the benefits, like it's almost just like, yeah, like there were corruptions in the church, and there was like all of these things, and I get all that, and that's put me in a place where I can remember the sense of what spirituality brings, and I feel spirit. I talk about it in the book. Faith means a lot to me, but it's not necessarily something that I can put into words. And sometimes it is a location, and sometimes it's not. Sometimes it is. But there's a definite sense of like searching that feels to me spirit. Like if I am searching, then it's very spiritual to me. And the searching can be, academically, but it could also be in like these relationships that I forged at the hospital, or different, or even around the world, just going around. Like, so I feel, I don't know, there is a sense of that. But I also think that it's interesting that we live in a time where formal religion is just not, it's not the same as it was like 50 years ago, like, and what that means, so.
You've kind of said this, but combining two questions. Are these challenges due to the type of economic system America operates on? And related to that, then, do you think the US really cares about making healthcare something affordable for all her citizens? Are there policies put in place? Now, you've mentioned for the Harris health system, but do you see any broader state or federal policies that are helping to regulate the negative impact of insurance on healthcare?
Yeah, that's a really good. I mean, one of the things that I've learned, and I mean, is that in general, institutions are not monolithic, and there's different sort of opinions. And I would say like the American governmental institution, there have been different opinions about this. There's been people who really care about healthcare, and there's been people who really don't care whatsoever about this. And that I think that it's one of the reasons why I thought like I was really immersed in the story of the CEOs of the United Healthcare CEO's assassination, because of what it said about our acceptance of those terms, you know, of like how it is, and that might, you know, prognosticate what's to come in other, you know, is violence going to end up being the solution? Or, you know, because you think about changes in ideas, revolutions, violence portends that often, you know. So it's I think that America, I think that there's it's unfortunately, yes, a lot of the problems that we experience in healthcare is fundamentally because of like the way that the United States is organized, both in terms of like state power versus federal power, and also in terms of like how the policies have been more, you know, corporate oriented for however long, and have prized those over individuals, you know. And I but I think that that doesn't mean it's a poison pill. I think that the democracy is a way to there's examples like this, where the fundaments of democracy can help, you know, overcome that. Is it perfect? No, but it is still something good. I see goodness there, you know, working there. So it's just something that we have to like. It's kind of like just something that we're always going to have to struggle with, and it's okay. There's no conceivable sort of government that I can think of that you wouldn't have to struggle with, because it's all about like weighing different ideas and ways of implementing them. So um, I see a lot of the benefits of the United States, I'm an internist, so I live in the world of risks and benefits. My mind is just like, what's the risk, what's the benefit? I just live in that world, and so if I have a criticism of a place, I'm always like, well, what's the benefit? That's like just part of how I live. And so when I pose these questions about the healthcare system, I'm also thinking like, well, what are the benefits? Like, I don't think I would be a writer if it wasn't in the United States almost. You know, I prize a lot of the free speech. So we have to we have to accept that this is going to be a struggle no matter what. But there's still, I think that the healthcare system is at an extreme. What my argument is that we are at an extreme level. That's what that graph is showing, and we need to like understand that extremes are not good for a lot of reasons, and we can like temper that.
Well, thank you very much. The number of congratulations, and thank you for being you kind of comments in the Q&A.
Oh, that's very nice.
Yeah.
I appreciate it. Thank you all. Thank you very much for sharing this time with me. I really mean it. I'm going to be in New Orleans for Mardi Gras, and I love New Orleans, and I almost went to Tulane for residency because I love New Orleans and Tulane very much. So thank you all very much for sharing this moment for me, for the invitation, and I appreciate it.
Absolutely. Well, thank you very much. And I was going to ask, but I checked it out myself. Straight Jesuit? Why, yes.
Yeah. Yes.
Hello, brother. So yeah.
Oh, you went to straight Jesuit also?
87. So yes.
Oh,
yeah.
wonderful. That's
While
wonderful.
before, but yes. So thank you everybody for attending, and what a wonderful talk. And thank you so much, Dr. Nuila.
Much appreciated. Y'all have a great afternoon. Bye-bye.